syndrome is from a lesion in the pons. I have paralysis, inability to speak, but I can still move my eyes vertically, and I can still lift my eyelids, and I still have some sensation. Often it's a real straight shot. So what do I mean by involuntary movement? I still have some pupillary response. I still have a corneal reflex. So if I touch my cornea with a cotton ball, I'm going to close my eye. If somebody shakes my head side to side, my eyes are still stable. They're not going with my head. I still have a gag reflex, but I might have some irregular breathing. We're going to talk more about delirium versus dementia in the spring. But what I want you to take away from this is that delirium is sudden and comes from an underlying condition. And it happens like that. It is a medical emergency. If somebody becomes delirious, sometimes it can just be as simple as, hey, that's feeling a little bit more confused than usually is. It's usually pretty with it. Medical emergency. Delirium is why baselines are so important. All right. Let's talk about ICP. I'm sure everybody's so excited to talk about this. So, what is ICP? The volume and pressure of the brain tissue, blood, CSF, and our skulls. It needs to be between 10 and 15. If it is persistently above 15 and it's going above 20, you run the risk of herniation. Something that's very important with ICP is this Neuro-Kelly hypothesis. Because of that zero matter, there's very limited space within our brains, or within our skulls. Well, that's a skill. Let's say skull. I am notorious for spelling issues. I apologize now. Increase in any one of blood tissue, blood, brain tissue, or CSF causes a change in volume of the others. So if my CSF goes up, my brain tries to compensate by decreasing blood flow. We shift or displace CSF with those villi, right, in that arachnoid space, tries to reabsorb it back into our venous system, trying to get rid of it in our brains so we have more room for the blood and tissue. Or we just stop producing it. Or, like I said, we decrease blood volume in general. With me so far? Makes sense, right? Only have so much room. What can increase my ICP? Head injury. Brain tumor. High CSF. Any type of hemorrhage or hematoma. When we talk about hematoma, we'll see that sometimes the space is so low that now my brain tissue is increasing, so I need to decrease my blood flow or my CSF. Any type of infection? Hypercardia, what is that? Increased CO2. What does that do in my brain? It causes vasodilation. And if I vasodilate, what's coming to my brain? Oxygen and think it through. If I'm dilating, what can get to my brain more? Blood, right? That's one of those main components, right? Any type of endotracheal or oral tracheal suction, coughing, increased intra-abdominal pressure, all that stuff puts pressure on my brain. Extreme neck, hip flexion or extension, and head have been less than 30. Because if I do either one of these, if I have head bed less than 30, extreme hip or neck flexion, I'm not allowing the blood to flow out of my brain. Most of the time, people with neuro disorders or head injuries need at least 30 degrees. There are some cases where less than 30 degrees is better, like you had one part puncture. But for the most part, we want that blood to flow out. What things increase our intra-abdominal pressure besides coughing and suction? What are that? Straining.
Tight clothing.
Tight clothing, right? I got my belt on. Maybe I gotta loosen my belt. All right. Let's talk about some more now. The brain can maintain steady perfusion if my systolic blood pressure But anything over 20, I'm still running that risk of herniation, right? The next thing we need to talk about is cerebral perfusion pressure. It goes very closely with my blood pressure and my ICP. My cerebral perfusion pressure is a big fancy term for the pressure that's forcing blood and oxygen to my brain. I take my MAP, which you guys can learn in cardiac, mean arterial pressure, and subtract my ICP. That's my CPP. You see about 70 to 100. If it's less than 50, I have irreversible neurological damage. Why? What's not getting blood in? Oxygen. And what happens to my brain tissue when I don't get oxygen? It dies. It gets infarcted. Does that work? I don't know. If my ICP equals my MAP, I have zero cerebral perfusion. It's a very delicate balance. If my CPP is too high, if it's above this 100, I'm going to have cerebral edema because too much is getting pushed up there. So what happens? So, if I have too much ICP, my body's going to compensate by trying to increase my cerebral blood flow. Also, there's a lot of pressure all up in here. That's a lot that my arteries have to fight against, right? So that's why I get ECG and cell death and my Cushing's triad. Cerebral edema, decreased CSF production and flow, impaired auto-regulation. So, because my CSF is low and my pressure is too high, my brain swells because now my brain doesn't really know what to do. It's accumulating fluid to just try and protect itself. It swells to try to regulate the decreasing CSF production. But now because of this impaired autoregulation, my brain's trying to change the way my blood vessels are. It's trying to make them, the diameters a little bit less. I can't sustain this. Impaired autoregulation is going to also decrease blood flow. A lot of these are all connected. These are the two main consequences. Oh, sorry, brain, but should be the brain. The main things I want you guys to take away: when I have too much ICP, my brain can slow. I'm not going to have great blood flow. It's going to lead to ischemia and cell death. If I have too much ICP, my brain's going to try and shift the best way that it can, and it can herniate down. How many times have you guys watched Grey's Anatomy and Dr. Shepard's patients for herniation? I don't know how he's still a surgeon. I'm really excuse joke. Other things that can happen: diabetes insipidus and SIADH, syndrome of inappropriate ADH. You guys will learn about that in endocrine. I'm not going to go through it. I think that's me. But essentially, what happens is that your body either produces too much ADH or too little. And ADH is the antidiuretic hormone. So either I don't have enough ADH, so hold on to too much, or I have too much ADH. I'm sorry, too much ADH and I'm holding on to it, too little ADH, and I'm taking out too much. I'm not going to guys what this about. That's more endocrine. I think it's cool that you guys have to teach you that before you have endocrine. brainstem reflexes, and my respirations are impaired, I'm probably brain dead. Any sudden change in your patient's condition has neurological significance. Talk a little bit more about positioning. So, if I have extended legs, and my wrists are here, toward this. Hands are towards the floor. That's how I remember that. The cerebral should be in the way, but still extended. Let's go. So, how the heck do you guys remember all this stuff? You might be asking me. Hey, your mind is crushed. So, you know what you're saying. I have horrible handwriting, sorry. And mental status.
I think the whole room's up. Thank you.
That is your restlessness, confusion, or not responding to questions. This is your early sign. I, irregular breathing. This is the late sign. N, nerve changes, specifically to your oculomotor. So this is your pupil issues or double vision. This is an early sign. Not the earliest, but early. D, decerebrate or deported. Flash list. Let's go. This is a late sign. Fun fact, this one works. Don't know why, but it is. Everything in your books, everything in my reading just can say disturbance works, but it doesn't explain why. Love that for us. Guys, with me so far? Probably should have done this up. That's in the right direction on this side. Crushed. C. This is your Cushing's triad. Does anybody know what this is? What is it? Close. Increase. SAP. Decrease. Diastolic blood pressure. Decreased heart rate. Decreased respiratory rate. Just a little bit more specific to what you said. Yeah, just ever so slightly more, because, you know, it can't just be simple, right? This is like R. Reflex. Does anybody, can anybody guess what you think the worst brainstem, or not brainstem, the worst reflex is that tells me there's some sort of brain death?
Yeah.
I think I heard something say Babinski. Babinski. What is the Babinski reflex? The toes flare out. This is like, this means that there could be some sort of brain death. Anytime you see the Grey's Anatomy, they just randomly go to someone's foot and flick it or whatever. That's a positive Babinski. Positive Babinski in an adult is a sign of brainstem death or brain death. Or severe, almost brain death, like we get there, maybe not. U is unconscious, which is a late sign. Just because someone has ICP, increased ICP, does not mean they're necessarily going to be unconscious. But as it increases, the worse their unconsciousness gets, right? Forgot the S. Slow reaction. headache, another early sign. E, emesis. This is late. It's also projectile vomiting. It's not just a little bit of spit up. Okay. And then D, deterioration. Of motor function. They're starting to have some sort of paralysis. Well, what is the first sign, the earliest sign of increased ICP? Change in level of consciousness and agitation. Mind rush, just like everybody else is today, right? Do you think it's important to determine what is an early sign versus a late sign? Yes. Why? Early intervention prevents those late signs. What do you guys notice about the late signs? Irregular breathing, poor posturing, Cushing's triad. What do you notice about those? What's the kind of the common theme there? Serious damage, almost irreversible damage at that point. That's why ICP monitoring is ICU level. You are one-on-one with that patient. It's practically sitting in the room with that patient for your entire shift, just watching that ICU. Everybody get that with them? Okay. Next, what can you do to decrease ICP? You might ask me next. I have another acronym for you. You can't tell about acronyms. Think pressure. D. Position the head of bed 30 to 35 degrees with the head midline, no flexion of the head, neck, chest. Why? So is that promoting? How drainage, blood flow. Respiratory, preventing hypoxia and hypercapnia. Why? Why do I care about hypercapnia? Don't want the backflow because of what happens with hypercapnia. Increased blood volume because of vasodilation. So I'm going to monitor ECGs, O2. Now, I can suction, but if I suction too long, that's going to increase my ICP, right? No more than 15 seconds. Elevated temp. You want to prevent this. Because if I have an increased temp, it means I have more metabolic needs. And if I have more metabolic needs, my heart rate increases, my blood pressure increases to try and get more blood to my brain. So that's going to increase my ICP. So whether my ICP, so let's say my ICP is because of meningitis. So I need to monitor their infection. I need to monitor the Cheese, yeah. What are we making sure is pain? Their airway. That's it. Or we're gonna say, the higher the temp, the faster cerebral edema will work. Your book on page 2008 has a great table outlining all of these interventions. I didn't know if you can look actually were there. I'm sorry. 2008 in your textbooks has a really good table outlining interventions. So diagnostics again, if somebody's telling me to be some ICD, CT MRI, angiography, tech inspect, transcranial Doppler. What is that going to look for? Carotids, and also it can tell me blood flow in the brain itself. EEG, spinal lumbar puncture, herniation. All right, let's dive a little bit deeper into cranial monitoring. All right, who do you think inserts this? Inserts these? Neurosurgeon, where? It can also be done in DPR. It can also be done bedside in CCU. There, if you become a CCU nurse, which grasp it, you may have to help the provider set up ICP monitoring. You might be assisting in the insertion of these devices. So there's three types, right? So let's talk about the intraventricular. Also called a ventriculosity. Oh my gosh. It's a fluid-filled catheter. We typically do it on the right ventricle. Don't know why. And then we have to get a bird hole first. Another thing if you watch Grey's Anatomy, they talk about every day. It's connected to that three-way stopcock, so we can take drainage out. CSF out. We can monitor the pressure inside the brain. We can connect just like a bag to help free flow. We can also inject medication if we have to, right into the brain. Maybe we need to do a intraventricular antibiotic. Maybe we need to inject air to try and see how the CSF is flowing. Maybe we need to inject contrast. We can do all of that with the ventriculosity. But we do run the risk of infection and meningitis. We run the risk of collapsing the whole ventricle. Or the catheter can include. Do you guys think that this is an aseptic setup? Aseptic or sterile?
Sterile.
There you go. Sterile, sterile, sterile. Next, you can have our little subarachnoid. That bad boy. It's hollow. It can either be a screw or a bolt, again, through a burr hole. Usually it's a twist burr hole because this is a screw. So we literally twist it in. Also, fluid-filled tubing, and it has a transducer for monitoring. So if we don't need to take CSF out, we don't need to put anything in, we do the subarachnoid just to monitor what the ICP is. But where the transducer limit has to be level, so let's say the transducer is over here, it has to be level with your ventricle. Otherwise, you're going to have misleadable ICP. You're not going to have the back after it. And then you can have an epidural or subdural. This is a fiber optic sensor, still through a burr hole. I still don't understand how this is considered non-invasive, but it is. I guess it's because it doesn't crop the dural, but I'm pretty much still wrong. And then a cable is then connected to a pre-calipered monitor. So that's a little bit trickier, right? Because you have to make sure it's calibrated correctly. This one you have to make sure you're sterile. That's why this one, I don't know, they really do the intraventricular most often because it's the most accurate. But these two are the new ones. Oh, that's not to say too that, like, let's say in yours, you steady, start with one of these two, and then we get to go far and we put one of these in after.
diluting.
So if there's glucose in my intravascular space now, where does my glucose want to go? Into my cells, right? My cells love glucose. What follows glucose into the cell?
So I have
Potassium, right? So, if I have low potassium, that is not spelled correctly. If I have low potassium, what else am I at risk for here? Heart problems, dysrhythmias, right? That can also lead to seizures. And why else can mannitol cause kidney injury? Besides making my kidneys work a little bit harder. All the extra sugar, right? Sugar is one of those bigger molecules. And my nephrons, when we get to renal, those nephrons are those little nets. And they're not supposed to let those big molecules through. But the more that glucose is coming through those nephrons, the more those are going to start to expand, and it's going to cause kidney injury. Contraindications. Urea, what does that stand for? Unable to pee, right? Do I want to get a diuretic if someone can't pee? Cerebral hemorrhage. Why? What is that? There's blood in my brain, right? So at that point, do I want to kind of keep my fluid in my body? Fluid volume overload or depletion. Because I don't want to add to the fluid volume overload by giving it salt. And if I'm already depleted, I don't want to deplete myself more. Interaction, as Brad says, plankton, all that fun stuff. Lithium, I will say it's because lithium's already a very delicate balance. So, and it gets excreted through the kidneys primarily. So if I'm making my kidneys back more, I'm going to excrete lithium a lot faster than it should.
I have a question.
Yes.
Sorry, just related to that fluid volume overload specifically. Like, we can put someone in just heart failure with that fluid overload, so you just need your lungs and stuff, but can you cause cerebral edema by fluid, like, does that make sense? Like,
Yes. Usually, cerebral edema is not caused by anything that we're going to talk about here. It's because of hyponatremia, which can happen if I'm overloaded, so now I'm all diluted. So now I don't have the salt to excrete the fluid and can back up. But mannitol, it's not going to cause cerebral edema, but it's going to be used to get rid of it. Does that make sense? Usually these patients have a catheter in because we need to monitor their eyes and nose strict. This is the go-to for any type of cerebral edema, unless the cerebral edema is caused by a brain tumor. Then we go there. Also, in your note section, that should be in there. There's a video. One said it's, I don't remember what her name is. She's a Southern lady, very nice. Yeah, there's Sarah. She did a really good job of explaining what mannitol does, how it works, and ICP and all that fun stuff. I was recommending her video, so I didn't put that in there as well. You will watch it. Okay. Everybody with me so far? Questions before we keep going? Okay. Yes.
What do you say that they use, if they have a brain tumor, it's not
Dexamethasone. Dexamethasone. Very, very strong steroid. All right. Into cranial surgery. So we can do a craniotomy. We just let me open that skull because we got to remove a tumor. We have too much ICP because if we take that skull off, including that neural matter, it gives me a little bit more room to go, right? Maybe we got to evacuate a clot. Maybe we got to get some blood out of the brain for hemorrhage control. Now, I'm not going to ask you any specific questions on your exam about like specific surgeries. Well, your NCLEX, maybe. The biggest thing to know about intracranial surgery is that if I'm going through the nose, thinking maybe I need to get a pituitary tumor, they're going to have that huge look thing on their nose after, and I need to monitor for what? Infection and what? neck straight. Or we can lay them side to side, but that's more for this approach. Not so much the pre-op, we're gonna do CT MRI, because we gotta see what we're gonna do, right? I don't want to go flying in their line, I'm not there to shepherd. Before surgery, we can do any intention visit, like a pin or a capra, because the risk of post-op seizures in brain surgery is very high. I mean, obviously, right, literally poking around in the brain. This is where we give antibiotics at a very specific time. Do you guys guess when that is? An hour before. An hour before what? The time the patient goes into the surgical room? No. The minute, the moment that the surgeon starts to cut, an hour right before incision. Why do you think that is? It's the peak of the antibiotics. That's the peak time that it's working to decrease my risk of infection after. Again, if there's any type of cerebral edema, we'll get mannitol, or tumor, we'll get Dextron before the surgery. What do you think is the most important thing to get before your patient goes down for a brain surgery? Mental status baseline, right? Depending on the surgery, you might have to get like a full fade going on here, a little slow hop things going. Sometimes they just need to take a little bit. Sometimes they have to take it off. The biggest things post-op: prevent seizures, preventing cerebral edema, pain control. They're gonna have a headache. I mean, literally just poking around in their brain. So, purples, we were talking about those holes earlier, they're literally holes in the brain. Sometimes we just need to determine if they're swelling. Sometimes we just need to see a little bit of what's going on in there. ICP monitoring. Or we can do what's called a craniectomy, which is just for taking out a portion of the skull, not the whole skull itself. Or, I shouldn't say the whole skull. Instead of taking this whole part, I'm just taking right here. Cranioplasty is removing the defect and replacing it with metal plate or plastic. I think nowadays they're going more towards plastic, unless you're somebody that hits their head off. So, specifically with ICP, we can do decompressive hemicraniectomy. So we remove part of the skull to allow expansion of the brain. And then once the ICP has decreased or they're no longer at risk for it, we can put the bone back. And we put the bone right in the belly. To keep it vascularized. You see that neural matter? So we can put one of those JV drains in there, like I was saying, to help drain that fluid out. And I will say, trigger warning, I have a picture of the real brain on the next one, so if you don't want to look at it, close your eyes.
Wait a minute, so wait, this bone that goes into this stuff,
Yes.
does this go back on here?
Ooh, fun.
Or they put them in like
Yeah.
I specifically didn't put this in like the one you guys have, because anybody can use it. So you can see that like spider web and stuff.
Yeah.
A little arteries. Nice round. Or not round, flat, no, gotcha. And you get a gnarly scar after. So this is right before they take the skull off. So they've taken the scalp and everything, they hold it back, and you can see the fissures.
Yeah.
So this where this they try to cut by the fingers just to get a cleaner cut. Yeah. So my dad with his strokes, he had to have a carotid artery bypass because his was so locked. So what they did something very similar, where they took, I think it was like this portion off, took out a couple arteries from his brain, and did a bypass of his carotid arteries. Kind of cool, right? Didn't work, but yeah. Oh, right. All right. He tried. That's all that matters, right? All right. Any questions? No? Sorry, I heard. I got your oxygen to my brain, so I have hypoxia and ischemia. And now, because my ICP is getting even worse, because I'm not doing something about it, I herniate, and then I die. Because my blood flow stops, right? Because NAP minus ICP equals CPP. NAP minus ICP is my cerebral, but if they're equal, then it's up, then I'm dead. Then I'm going back to RIP. So, I can have open or closed. Open. My skull integrity is still. What does it say? My integrity of my skull is compromised, right? Something has penetrated my skull. Maybe somebody hit me over the head with a bat, right? Closed. Blunt force trauma that causes acceleration and deceleration of my brain, but my skull is still intact. Mild to moderate or severe, depending on my Glasgow coma scale and if I pass out or not, and if I do, how long. Then it's primary and secondary. So primary is any consequence from the direct brain injury, right? Contusion, laceration, somebody hit me over the head, so now I have a hematoma or a skull fracture. Secondary is consequence hours or days after. So some sort of hemorrhage, I can't get oxygen or glucose to my brain cells, cerebral edema, epidural hematomas. Now your book lists external and subdural hematomas under primary, but then later on also put some under secondary, which I hated. But the most common secondary is epidural hematoma. That's probably what I did it that way. Now, just because I have a head injury does not mean that I have a brain injury, right? Sometimes I can have a fractured skull, but my brain is still fine. Scalp injuries are always classified as minor unless they're bleeding like a lot. But there's almost like little capillaries in our scalp, kind of like when you have a nosebleed and it seems like a gusher, but just because we have a bunch of tiny capillaries in our noses, it's actually not that much, and the bleeding stops eventually. So scalp injuries are kind of the same, unless they don't stop and they just keep bleeding, then it's considered more than minor. Sorry. So, oh yeah, so you can't just call something a skull fracture, we have to have multiple others. So, diastatic. That is when we have a skull fracture along the suture lines. Which is kind of nice, right? Because I mean, it's just gonna like form eventually. Depressed is when it actually comes in and broken. C is linear. And linear fracture, so it's just kind of going in a line. The linear fractures can become where it just kind of extends and it branches off, but it's still linear. Does that make sense? Like it's still going in a line, it's just kind of making its own timelines. And then basilar. So linear fractures always just go in a straight line, but sometimes they can become commuted. I can't say that word for whatever reason. Where it's still following a straight line, but it has like mini break-offs that are also still just following a linear line. I don't know why I can't say that word, but. Basilar fractures are the rarest. They're at the base of your skull, but they can damage that little brain and your spinal cord. If my skull fracture is not a depressed skull fracture, I don't need surgery, but I need close surgery. If I have a depressed fracture, I need surgery, right? That's literally like it's fractured into my brain, and that can splinter off and puncture my brain from there. Depressed fractures, I need to do the surgery within 24 hours. So, manifestations, persistent low blood pain, possible swelling. Basilar fracture is a brain bruise from the impact against the skull itself, usually in the anterior frontal temporal lobes or both areas. You can kind of see where how this is like the normal brain tissue here. You can kind of see that bruise right there. Okay. Usually there's a small period of unconsciousness with stupor or confusion after. These are 20 to 30% of all traumatic brain injuries. And it peaks with hemorrhage and edema, peaks at 18 to 36 hours. And then usually the secondary effects lead to increased lysosomal radiation. And really the only thing to do for this is to prevent all those worsening things down the road. There's no surgery, medications really are just for headaches, maybe some diuretics if they're starting to get some edema. This is what happens typically with car accidents and shaken baby syndrome. Usually they heal in a few days with rest, unless they're like really severe, and then it takes a few months. Concussion. So concussion has temporary loss of neurological function. Contusions do not. There's no apparent structural damage to the brain. So where there's is the concussion with contusion, there's not with concussions. Unless you have some different on there. So the longer your mental status is abnormal, the higher your degree of injury. And again, your frontal lobe, bizarre irrational behavior, because that's what the frontal lobe does, right? This is when you'll have headaches, concentration issues, balance issues, sleep disturbances, nausea, vomiting. Usually concussions are called mild TBIs. You'll have that brain fog. Has anybody here had a concussion? You feel like you're, yeah. You get like that brain fog. Sometimes you have that light and sound sensitivity. And the reason why this is happening is because your brain is like almost telling you to pump the brakes, right? Your brain's like, whoa, we need to slow down, we need to rest. So shit just went down, right? Sometimes you have some mood swings, and usually you're pretty fatigued. You don't necessarily have to go to the ER unless your loss of consciousness is greater than a minute. Or if your headache is getting worse and it's not going away, not able to tell. Or if you have repeated vomiting. Because what are all those a sign of? Pressure issues, right? Cerebral edema. You can usually they resolve within 72 hours unless you get diagnosed with post-concussive syndrome, which is when recovery takes like months to a year and occurs about 15% of people. But there's not much data about it because a lot of people don't actually get seen for concussions because you don't have to unless you meet those criteria, right? So not a lot of evidence on that. I almost put a picture from up here, but I thought that was rude. So CTE. We actually don't know everything about CTE, and a lot of it is still in the theory stages. So it's thought to be linked with repeated concussions, degeneration, and death of the nerve cells. So where this is a normal brain, this is someone's actual brain in an autopsy, this is somebody with CTE. Look at those vegetables, right? It looks like a turkey after Thanksgiving dinner. Sorry. Early symptoms. Your early symptoms if you have CTE is depression, suicidality, mood swings. I'll say mood swings are kind of the main one. Personality changes, aggression, which makes sense when you think about it. Balance or walking shoes, shaky, slow movement, because look at how much is shrunk, right? And it's affecting all lobes of the brain. As it progresses, that's when you get more short-term memory loss, confusion, you can't really plan or organize. It does not happen right away, it's a progressive disease. It happens about 10 years, again, it's all very theorized, about 10 years after your repeated injuries. That's why a lot of football players, you don't see it until after they retire. The only way to actually definitively diagnose CTE is autopsy after death. We can get CT MRIs, but we won't actually know until we go. It is rare, but it usually happens if you get another head injury before the first one resolves. Football. Really not even just football, hockey, all of conscious for just a few seconds or minutes, but loss of consciousness can happen longer than or shorter, sorry, shorter than this. This one is jarring with the brain, so it's going down, right? Whereas confusion, it causes it, right? It's not gonna fly. I can see a confusion on an MRI. Can't see one on a concussion. Let's talk about semantics. Wait, can we talk about semantics? So, something I want to point out. So you see how the epidural hematoma is pushing the dura mater, but it's supposed to be firm, right? It's not supposed to be movable. It's not changing how it's not stretching or anything. It's just getting pushed. So it's still firm. It's still rigid. It's just getting pushed, right? So I want you guys to keep that in mind. Because when I first was building this lecture, I was like, okay, how do I explain that? Because to me, it looks like it's changing shape, it's getting stretched, but it's not. Which is why epidural hematomas are a little scary. So, what are hematomas? Collection of blood in the brain. Usually symptoms are delayed until the hematoma is large enough to cause issues. Usually I'm increasing the ICP. If I'm pressing on all this stuff here, what do you think is happening to my blood vessels in my brain? They're getting compressed. And if I'm getting compressed blood vessels, I'm not getting oxygen, right? Usually hematomas are slow, but if they grow rapidly, even if it's small, probably be fatal. Versus large ones that grow slowly, right? Because my brain has time to compensate for this one. But if this just happened, my brain can't compensate for me. So, let's talk about who knows is late? Karen Chad. Okay? She died from epidural hematoma. Yeah. She's married. She was married to Liam Neeson, and he does not remarry. So, epidural hematomas are between the dura mater and the skull. So you can see here. See how it's getting like pushed over. And if you can tell too, I can still see this ventricle pretty well. This one I can't see that great, right? So it's from a skull fracture that causes a rupture or laceration in the meningeal artery. Rapid pressure in the brain occurs. So what happened? Like, Natasha Richardson. What happened with her? She was skiing. She lost her balance, hit her head against a tree. She felt fine. So she went back to the ski resort. She was like, I just have a slight headache. I'll be okay. I'll be okay. By the time she started having some signs of increased ICP, like confusion, worsening headache, vomiting, it was too late. And she hurt brain drain. So, loss of consciousness followed by lucidity. So she passed out for a second, but she's like, no, I'm good, I'm fine. But then her CSF was rapidly being absorbed, and we're trying to decrease the volume because her ICP was already increasing. She didn't know it, right? She didn't feel it because epidural hematomas form fast, and she couldn't compensate, right? So her symptom was very, very slight confusion and a little bit of agitation, and then suddenly she herniated. It's considered an extreme emergency. Respiratory arrest can happen within minutes. The reason why this happens with the meningeal artery is because that artery runs between the dura and the skull.
Did she, sorry,
Yep.
did she like die right away? Like how long did it take for her symptoms to like progress?
I actually looked this up because I was curious. I want to say it was within like a few hours.
Oh.
And it was like an hour later, because I think she went like took a nap. When she woke up, she wasn't great.
Which is like the worst.
they med flighted her, and by the time she got to the hospital, it was too late.
Oh, so it happened.
Yeah, she
that
died.
way.
So she went to a coma. I think she died like a few days later, but I think she was brain dead for a few days.
That's
Right. Immediately go and get a brain scan, right? But if you feel, how many times have you guys hit your head? You're like, I ain't. That's why the girl was scared of me. The amount of times I hit my head, so the only thing to really do about this is a verbal to decrease sensitivity. Maybe put like a catheter in to evacuate the hematoma. We might need a craniotomy or a dream.
Is this
they say, oh, the brain's coming out of the ears, and it's really fluid.
So when you speak of herniation,
Yes.
you're talking about like that dura layer like explodes open.
It's not exploding open. So what's happening here is my brain can't push against this. My brain can't come out here. So it goes down into my brain cell.
So it herniates.
So it's coming down this
It
way.
herniates into itself?
Yes.
Okay.
Or like in Grey's Anatomy, when necessarily open the hernia, sometimes it just like literally comes shooting out and there's nothing you can do about that. Right? Because it's out of the
Once you create the opening, but it won't create.
It won't create a hole.
But it will.
It'll go down into the brain cell.
Well, it comes through a burr hole.
Right. And when it herniates, it goes down the brain stem, and then it's excluding the medulla oblongata, pons, and all that fun stuff, and then. Right. Signs of herniation is usually like rapid coma, rapid deterioration of your mental status, dilation and fixed pupils. Subdural. Subdural condition. So, now the blood is between the dura and the brain. So epidural is between the skull and the dura. Now this is under the dura, next to the brain. It can be acute or chronic. So acute from head injury, usually from a fall. You have some pupillary changes, having paresis, because now instead of just pushing on my brain, I'm actually affecting the brain itself. Right? I'm affecting the lobe itself. I'm not just compressing it. Coma, increasing blood pressure, increasing heart rate, respiratory rate. That means that expansion is happening fast, and I need to intervene now. I need a immediate craniotomy for clot removal or bleeding control. Usually, this area between the dura and the brain has a little cushion of fluid, but in a hematoma, that fluid is gone in it. It's usually venous blood. And venous blood has what? Does the venous blood have oxygen? There you go. Or you can have chronic subdural hematoma, which is from a minor head injury, from atrophied brains. Symptoms can show from 3 weeks to months later, less profuse bleeding, but I'll have some ICP increases, but not too horrible. And it basically just becomes, the blood becomes thick and dark, it becomes hard, and then it becomes a foreign body for my brain to play. That's like a wicked slow bleed. And then what happens is people usually come in thinking it's a stroke, when it's actually a chronic subdural hematoma. So we put a drain in at that point, probably like right here, then draw the blood. Or maybe like a hole in the drain. Sometimes it'll be like a constant drain, like letting it come out slowly. Because the other thing too is that if this is compressing my brain, then I just quickly get rid of it all. That becomes a shit. I'm not giving my brain enough time to slowly compensate for the blood now. Intracerebral hematomas. Now this is like in the brain itself. From hypertension, aneurysms, tumors, bleeding disorders, anticoagulants, bullets, stab wounds. So this is an insidious onset of neurodeficits followed by headache. So it's slower. Really, the treatment is ICP monitoring, fluid electrolyte management, and supportive care. If you do a craniotomy, craniectomy, kind of get the blood out, but unless we fix what's causing this, there's really not much we can do, right? Like if let's say